Thank you. So my topic today actually came at the request and feedback from last year to have another ethical discussion, and it's certainly something I'm very passionate about, as you will see. So the format of this talk is really going to be 3 case studies. I'm going to present to you a case where people legitimately did not know what the answer was, what to do, what was right, what was wrong. That study of ethics is really what should we do, what ought we do in a situation where sometimes there is no right answer. So we're going to start with Frank. And Frank's a 68-year-old male with a 10-year history of idiopathic Parkinson's disease. So we got Mohammed and Michael J. up there. And he takes Sinemet, Azilect, Requip, all with effect, but he's starting to require more and more dose of medication. He has these troubling dyskinesias or abnormal writhing movements. Those are secondary to the medication dose required to treat his Parkinson's symptoms. Remember, the symptoms of Parkinson's, the cardinal symptoms, are tremor, rigidity, slowness, and freezing. And he has a friend from church who just underwent deep brain stimulation and is now doing very well and on like a fraction of the dose. Like used to take 8 pills a day, now takes 1. And his physician has never mentioned DBS for him. He starts looking on the internet, and he wants to know why. So what's the big deal? So his doc never told him about DBS. He's treating him with all of the basic medications that should be treated with Parkinson's for Parkinson's. He's doing the right things medically. What's the big deal? Some therapies are good for some people, some therapies aren't, right? Not everything is right for everyone. Well, I certainly agree with that. Not everything is right for everyone. So the next question is, what's my responsibility as a physician, as a care provider, to provide the appropriate recommendations for my patient? If I don't know much about a therapy, then I shouldn't really go around recommending to my patients, right? Because, if I don't know about it, I don't know what might be right, what might be wrong. I don't want to get their hopes up. But can you see how Frank might feel a bit confused or perhaps even betrayed by his trusted neurologist, somebody he's seen for years and years, that his friend down the street saw somebody different and got offered something that seems to be a miracle for him, and all he's getting is more meds? Can you see how he might be afraid to advocate for himself because, in fact, they've had this long-term 20-year relationship and everything's gone well. There's no animosity. There's a lot of trust there. And how this questioning and this fear can cause a rift in what is a very good and high-quality physician-patient relationship. And why, overall, might it erode trust in our healthcare system as a whole? Now, imagine if Frank were a Medicaid patient or, for instance, African-American. And might he feel that the reason he's not being offered this is because it's an expensive treatment or because there is some other type of discrimination going on? Now, certainly, it doesn't appear from his long-standing trusted relationship like that's the issue at all. It really just appears as if it hasn't been something that's recommended to the patient. I picked DBS for this talk, but this could be applied to any innovative therapy that we're talking about. I picked DBS for this one. So there's this idea or concept of a duty to care. It's an idea that the physician impliedly agrees with the patient that he or she, the physician, possesses this reasonable degree of learning and skill in the profession. So they went to med school, they did a residency, they've passed their boards or they're board eligible, and they have the skill that any other physician that's a reasonable physician with their specialty might have. And then on top of that, it's this idea that the physician agrees that he or she will use their best skill and judgment in diagnosing a patient's disease or ailment and apply the best mode of treatment and will exercise reasonable care and diligence in the treatment of that case. So essentially, you're going to provide the best possible care, the best possible judgment, and you've done your homework. You went to school, you did your residency, you read your papers, you know what you know. There's also the International Code of Medical Ethics, and that really states that a physician owes his or her patients complete loyalty and all scientific resources available to him or her. And I want to emphasize the all scientific resources available. And there's this concept that informed consent applies equally to refusal of treatment, but it also applies to choosing among alternative treatments. So it's not informed consent when you're treating a patient and you only tell them about the treatment that they want and they can say yes or no. If you think about our informed consent process, and we all have these phrases, risks, benefits, and alternatives were explained to the patient, and the patient was given the opportunity to choose for him or herself. Now I want to talk about within this theory. So we've talked about this physician who has a duty to care, and under the International Code of Ethics has a duty to provide informed consent that would include all the scientific evidence available, reasonably available for their patient. And it's this idea of distributive justice, that it's a common theory. It was put out there originally by Aristotle that common to all theories of justice is a minimal requirement that essentially all things being equal, people are treated equally. And this quote came from Beecham and Childress, who are sort of the fathers of biomedical ethics. And so logically, when all circumstances are equal, then everyone is treated equally. So if Frank and his friend were on the same drug regimen, and they've had Parkinson's for about the same period of time, and they're looking about the same, then distributive justice, this concept, would equate that they should both be at least offered the opportunity for this treatment, to make the decision for themselves. If you'll notice, we're talking about justice, we're talking about autonomy, we're talking about something called principlism in medical ethics. So there's 4 basic principles, and we're going to get to a couple more later, but autonomy being this idea that you have control over your own self and your own body. Justice meaning that we distribute medical care or other issues around medicine equally and with all due fairness and without discrimination. So there's a concept that Daniels, who's a biomedical ethicist out of Yale, talks about, and it's this idea of fair, equal opportunity, not to have the same treatment, not to have the same drugs, not to see the same doctor, but really for participating and enjoying in life. So he's really concerned about this undeserved advantageous or disadvantageous circumstances that might give somebody social benefits. So one might say, if it's undeserved, that it really is the properties that are acquired socially, and if it's deserved, that it's a biological lottery. It's not Frank's fault he got Parkinson's, right? And it's just a lottery, whether it's his genetics or multifactorial, whatever the reasoning might be. And so the fair opportunity rule would state that we as a society have a responsibility to provide healthcare services that ameliorate the symptoms of a condition, not to make them equal, one person equal to another, like Aristotle said, but more to give them an opportunity to fairly participate in their life just as much as I have an opportunity to participate in my life. So does deep brain stimulation do that? Well, yes. So the answer is unequivocally yes, and we have over 100,000 people in the world, we just surpassed that about 3-4 months ago, who have deep brain stimulation implants. So it's not experimental, it's not anything questionable, and this is just some data, this is some early data. On time is on medication or getting an effect, and on time without those abnormal dyskinesias improves from 27 to 74% of a patient's waking day. Well, that's huge. Furthermore, these symptoms continue to be improved after 5 years with a slight decrease in the akinesia or freezing, but the tremor and the rigidity are maintained, and this is an off medication. This is on no meds at all. They also get an extra 4.6 hours of on time with their medications without dyskinesias with DBS versus none on medication. The most telling piece of data is this slide right here, where everything above that line is an improvement, everything below that line is a worsening. And neurostimulation is in blue, so deep brain stimulation is the blue line, and medication alone is the bluish-gray line. So you can see in every single range across the board, people get better with neurostimulation, and in every single range across the board, people get worse on their medications. So there's, without question, data that shows that deep brain stimulation really is an effective treatment, something that actually fulfills this right to fair equality or fair opportunity. This is a study, further studies. This is a study from the Journal of American Medical Association. So don't trust surgeons, trust medical doctors. They're far more, shall we say, they're far more likely to be conservative than surgeons, or at least that's the perception. And this concludes that deep brain stimulation in a randomized controlled trial is as effective. Exciting to me, and this is some new data for most of you in the room since it was just published in February of 2013. Happy Valentine's Day. It was actually published on February 14th. This was the early STIM trial published in the New England Journal of Medicine. 251 patients just started having those mild fluctuations, so earlier than we have typically implanted for deep brain stimulation, and they were all still responding well, so they weren't having their wearing off periods, they weren't having dyskinesias. They randomly either got deep brain stimulation plus meds versus medication alone. Patients in the DBS group experienced an improvement of 26% in their quality of life. This was statistically significant. Mobility was also improved in the combination group, and the findings suggest that at least instead of waiting for them to have these marked up and down fluctuations, peaks and valleys, we move into a situation where we treat them before they start developing this. So we treat them even earlier. So even more than just should he have been offered the therapy, it really is that now we're knowing we should be offering the therapy sooner and sooner. So what are our obligations? Because obviously, we can't know everything about everything. That's an unreasonable expectation for physicians, for nurses, for physical therapists. We do have an obligation to stay current on our field. We should all be reading, no matter what our field is, whatever the journals are, on a regular basis, to keep up with what's going on, to know what the science shows. We also have an obligation to present treatment options to patients, even when they may not be ones we know much about. And it's an interesting idea that if we're open and humble about patient approach, that if Frank were to say to his neurologist, you know, Dr. Beasley, my friend had this DBS, what do you know about it? Is it for me? The appropriate response, a good response might be, if I didn't know anything about it, you know, I don't really know, but let me make a phone call. Let me call somebody that might know. Refer out. You can always send somebody to somebody else. You don't look like an idiot. You just look like somebody who's interested in giving your patient the best possible care. And it's also a learning opportunity, because if I have a patient who comes in and asks me about, what do you know about X procedure, and it's not something that I know much about or I've learned much about, what that should prompt in me is this idea, this thirst for knowledge that we all have, to really go and seek it out. I want to learn something new. I want to learn something new every day that I do this job, and the day I don't is the day I quit. And that's that kind of thirst for knowledge and hunger that we as scientists and healthcare providers should have. So it's certainly not an affront to us or a threat to us to really step back and step out of ourselves and our own ego and say, you know, I don't know, but why don't we check it out? That's fair. So again, this can apply to any therapy that we don't know much about. I just chose DBS because that's my baby, right? Let's go to our next case. So this is Tim. This one's really controversial. Tim is a 56-year-old homeless male. He presents to the emergency department drunk after falling out of a tree. He's neurologically intact, so he has no motor deficits, no sensory deficits. He has a lot of neck pain, and he has an MRI that shows some significant ligamentous disruption, as well as stenosis and degenerative disease. So what's the dilemma here? Well, he has this severe ligamentous instability. He also has degenerative disease that wasn't from falling out of the tree, but the combination of the two create a situation whereby his neck should in fact heal on a collar, a cervical collar, if he were to wear it all the time. But the other options might be to placement a halo, or to do an anterior or posterior or just an anterior surgery, depending on the surgeon's preference, but a surgical intervention. So in the hospital, he's completely non-compliant with the collar. He takes it off, he rips it apart. He doesn't just take it off, he rips it apart and modifies it so that he likes it a little bit better. He refuses to quit smoking and leaves the floor to smoke. And we all know, and we've covered before multiple times, that smoking is an independent risk factor for non-union in cervical fusion, and also for wound healing difficulties with any surgery. And so what do? And what's the right thing? If you leave him in a collar, he's not going to wear it. If you put him in a halo, he's going to fall down, end up with a pin in the brain, and then you got a bigger problem, or he'll rip it off and lacerate his skull. He's just the way he modified his collar. I am sure Tim is going to be able to modify his halo with worse detriment, right? If you operate, he's of course high risk for non-union. He's risk for infection and a whole slew of other operative complications. Any option, he's not following up with you, right? What do? You can't hold him in the hospital. You can't tie him down with the collar for 8 to 12 weeks. So here's where, when we're talking about principalism, we'll talk about this idea of autonomy. And autonomy is the personal rule of the self, free from controlling influences by others, and from personal limitations that prevent meaningful choice. So autonomy is this idea that you get to choose what's right for you in all situations, as long as it doesn't hurt somebody else, right? So autonomous individuals, they act with intent. So they do something on purpose for a reason. They have understanding. So you have to fulfill these criteria. You can't just say somebody's autonomous, but they're completely demented or what have you. So they have to have understanding of the consequences of their actions. And they can't have somebody telling them what to do or holding something over their head or trying to bribe them or coerce them in some way. And so for a physician, traditionally, there's almost this sort of overarching respect for our autonomy. Of the 4 principles we'll talk about, it's the one where everybody goes, this is the one. And sometimes it's not always the best principle, but for physicians, respect for autonomy includes respecting an individual's right to self-determination, as well as creating the conditions necessary. So giving them all the information that they need. So just as Tim may jump right out of his fishbowl by ripping off his collar, we need to present all the treatment options to the patient, just like we talked about before in the last case. And we have to explain the risks in terms of things that the patient understands. We have to say, Tim, you take this off, you fall down again, you can end up paralyzed. You can end up not able to move your arms and legs. You could end up not able to evacuate your bowels yourself, wetting yourself, all of these things. And that's not being mean or cruel or coercive. It's explaining it to him on his terms. And then ensuring that he understands the risks if he's going to undergo a procedure. And for Tim, that may very well be saying, Tim, here are the risks. Now you tell me what you heard. I want to know what you heard, so that you really understand what Tim knows or what he doesn't know. Here's another principle, and that principle is beneficence. It's an action that is done for the benefit of others. Well, we do that all the time, right? We sure as heck aren't up there at 3 o'clock in the morning for the 4th time in a row operating because it's fun. It is fun, but we aren't doing it because of that. We like to be home with our families too, but we give of ourselves in the benefit of others. That's one of the key components of being a healthcare provider, no matter what you do. And so actions that can be taken to help prevent or remove harms, improve the situation of others, and ideally, if we're talking about in a perfect world, beneficence is really these extreme acts of generosity. The guy during the flood who threw himself into the raging water to drag the other guy out of the car, even though he didn't know how he was going to get out there. I want to point out that physicians are not necessarily expected to live up to that ideal broad definition. There are limits and reasons. So the goal of medicine is really to promote the welfare of patients. And physicians possess those skills and knowledge, and that's why beneficence is a principle that should be applied in medicine. So due to our nature, due to the nature of the relationship, the personal, intimate nature, physicians, doctors do have an obligation to prevent or remove harms when necessary, and to weigh and balance the possible benefits, and really explain what the difference between those are. So some examples of some beneficent actions: resuscitating a drowning victim, vaccinations for the general population is beneficent, encouraging someone to quit smoking. It doesn't have to be some you don't have to hear the angels sing like it's this amazing act. Really just talking to your patients about quit smoking, that's beneficent. It takes time. Another principle, we're going to talk about non-maleficence. So this is the 3rd of those principles, and it's that primum non nocere from the Hippocratic Oath. Above all else, do no harm. So physicians should refrain from providing ineffective treatments or acting in malice towards a patient. So we shouldn't use treatments that are proven not to work just so we can get paid, for instance, and we shouldn't act with malice towards a patient because they've angered us or irritated us. And But that's really not that useful. Isn't that what we do most of the time, right? Some of these therapies also have significant risks, like we're talking about with Tim's surgery. I mean, there's risk of vocal cord paralysis, there's risk of pneumonias, there's risk of non-union, there's risk of infection. It's not a small procedure to do his surgery. So the pertinent ethical issue is really which one of these principles outweighs the other one? How do we balance? How do we figure it out? And so some examples of non-maleficent actions are stopping a medication that's been shown to be harmful, like the diet drugs that cause the cardiac issues, refusing to provide a treatment that's not been shown to be effective. Those are non-maleficent actions. So in this case, what we really had to do is remove the emotions, and this is really important. Guess what? We're all human, no matter what it is that we do. Nurses, doctors, physical therapists, Tim, everyone is a human, and we're all emotionally connected. And so you're allowed to have emotions about the patients you treat. But in this situation, those emotions can be anger. I told him to stop the smoking. I told him to wear that stupid collar. He is not listening to me. What am I going to do? What kind of an idiot is he? That doesn't help, right? And it can harm. It can add that malice. Frustration. You have had this talk with him. You've taped the collar on. You have sat him down. I mean, you have done everything you can possibly think of, and he's just not doing anything. And then there's this moral angst. You're upset. You go home upset every night. What do I do? What's the right thing to do? If I send him home, there's going to be a problem. So we have to separate ourselves. We have to recognize and accept those emotions. They're not wrong, and we can have them. We just have to make sure they don't bleed into our interaction. And sometimes that's really hard to do. So how do we balance all of these? So balancing autonomy, beneficence, and non-maleficence. So in this situation, the potential benefits of any intervention must outweigh the risk. We talked about that. And autonomy in this situation is not the supreme principle. It's not just Tim gets to say what he wants to do because all three of the options are the same. And so in this case, surgery could violate the principles of both non-maleficence and beneficence, and the patient could experience great harm with very little good, because if he has the surgery or he has the halo put on and it hurts him, he has infused, so his problem's not fixed, and he's got bigger problems than he started out with. Furthermore, I want to argue that Tim's already exercised his own autonomy in as much as he chooses not to wear the collar and he doesn't quit smoking. That's an indication that he's made his own choice. You know, you told him what his risks are, he's made his own choice. And so I give you the analogy, somebody who has a history of overdosing on narcotics, they come into your office and they have a real issue with pain. Are you going to write them for OxyContin again when they were just in the hospital on Narcan and almost died last week? No, you're probably not. You're going to look for something else. And so in this situation, I think Tim's really exercised his autonomy by climbing the tree. The last case is Mary. And Mary has chronic regional pain syndrome of the left upper extremity after a wrist fracture. She's had it for 10 years. This is not somebody new. And chronic regional pain syndrome, for those of you who know or don't know, they get skin changes, they get swelling, they get this horrible, terrible, awful, burning pain that is oftentimes intractable to treatment or medication. You can't touch their skin or it causes terrible pain. These are called dysesthesias or allodynia, and it can be debilitating. And in Mary's case, and this is a true story as well, the pain was so severe she wears bandages over the whole extremity so that nobody touches or brushes her arm. And she changes them very infrequently because, of course, it hurts to change them. She spends most of her days with her arm propped up on a pillow, not moving it, and now she has contractures in her hand and severe atrophy of her hand, so it's really a non-functional limb. And because she doesn't change the bandages on her arms, she develops a cellulitic skin infection that she then gets put into the hospital to be treated for with antibiotics. She's tried chronic pain management, including multiple narcotics, including all of the modalities that are available to her, not just narcotics, but antidepressants and membrane stabilizing agents such as Lyrica and Neurontin, and ketamine. She's had ketamine infusions in the hospital. She's had a spinal cord stimulator cervically. None of it helps her pain. She said, you know what? Cut it off. I don't need it anymore. I don't want it anymore. There's no medical reason to cut this arm off. Furthermore, Amputation really is not likely to help her pain, as given the way that she has this sort of abnormal neuropathic pathway going on, she's likely to develop phantom pain, so you cut off the arm and she still has the pain anyway. So what obligations do physicians have to participate in these unconventional treatments that are at the request of the patient? Does Mary have a right to ask? Well, she has a right to ask, but does she have a right to demand this treatment? It's her arm, it's her body, she wants it gone. It's our responsibility to do what she wants. So, can a patient demand treatment? Well, it's a common misconception that patients have the autonomous right to demand. I have a cold, I want an antibiotic, give it to me. And furthermore, this idea is perpetuated with the whole idea of patient satisfaction and pay for performance and these HCAP scores where patients, if they're unhappy, nobody gets paid. So people are very frightened in our society today of not giving the patient what the patient wants. Easier to just give them the antibiotics. Now, I'm not saying that an amputation is equivalent to antibiotics, but it's that same idea. They don't have a right to demand. And so there's two different types of autonomy since we're really looking at these principles. There's negative autonomy, which is the right to refuse medical treatment. We don't argue. Everyone accepts that you have the right to refuse medical treatment. It's been upheld in a series of court cases. And on top of that, it's really hard to force treatment on somebody who doesn't want it. We've done it before in the past with the Dax court case, the guy who was burned in the 70s who wanted treatment stopped, and we forced it on him anyway. He survived. He's now an attorney. And even though he has a beautiful life, he says, you know what, you should have respected me. So we don't argue that he had the right. We did then, we don't now. We automatically accept. Somebody doesn't want chemotherapy, that's their choice, as long as they understand. But there's also this idea, and in Mary's idea, it's this positive autonomy. She's kind of trying to hold the gun to the physician's head and say, I demand this. It's my body. This is what I want to do, and you need to provide it. This isn't as compelling an argument. The paradigm is that the professional, us, we have a right to refuse to provide a requested procedure if doing so would violate our professional conscience or our professional judgment. Not our personal conscience or personal judgment, but our professional conscience or judgment. And this has been well established in U.S. federal law, state laws, and even in international law. So again, we have this dichotomy, non-maleficence, beneficence, and autonomy coming together. So what is a physician allowed to refuse, right? There's a legal standard. You can refuse a request for a non-approved drug. Somebody wants to take a drug that's experimental and you have it. You can say, no, it's not approved. I'm not going to give it to you. There's the professional standard. So requests for non-beneficial treatment, such as antibiotics for a virus, or hyperbaric oxygen for a completed stroke. Those would not, you can say, no, this isn't in my best medical judgment. You're welcome to get another opinion. I encourage you to get a second opinion. However, I'm going to refuse this. There's clinical judgment, just as we talked about, and then there's personal choice. In a non-emergent situation, doctors are free to refuse patients for non-discriminatory reasons. You don't as long as you're not discriminating against that person on the basis of the fact they can't pay you, or that their gender or their sexual orientation or their religion or any other reason. If you're just saying, all things being equal, this is not something that I'm going to do in this situation, you can do that ethically. And you should do that, because you have that moral angst and need to go home, and you need to do what's right at the end of the day. So bringing it all together, we've looked at 3 cases. We looked at all of these principles: autonomy, beneficence, justice, non-maleficence. Each situation is unique, and each situation requires a balance. And I want to point out, no one principle reigns supreme. Right now, and it's our instinct, autonomy reigns supreme. That's not always the case, and we need to step back. We need to look at who the stakeholders are in a situation, what values there are that might be lost, both to the provider, the patient, the caregiver, society, the institution, and ultimately, we need to balance those out. And so I'm going to leave you with this thought. Leo Tolstoy, it's not given to people to judge what's right or wrong. People have eternally been mistaken and will be mistaken, and in nothing more than in what they consider right and wrong. So on that note, we'll move to our questions. So true or false? Under the ethical principle of autonomy, physicians are obligated to provide a requested treatment for a patient even if that treatment has no sound medical data. True or false? Nice. Yes, that is correct. So if there's no sound medical data, you are certainly not required to provide it just because a patient wants it. Next question. The 4 principles of medical ethics proposed by Beecham and Childress are, which one of the 4? Excellent. Autonomy, beneficence, non-maleficence, and justice. Next. True or false? Under the principle of positive autonomy, a patient has the right to refuse all treatments offered to them. So this one was actually a trick question. That's negative autonomy. When you have the right to refuse your treatment, that's negative autonomy. So sorry, I was being a little tricky there. You know, ethically, I wanted to know how many people were paying attention. So under Daniel's idea of the fair opportunity rule, it states that society should provide healthcare services that provide each and every person the opportunity to participate in and enjoy life. Which principle or rule does this reflect? It actually is B and D. It reflects the principle of beneficence because society is doing something to help someone else, and it's justice because we want to provide them with the same opportunity that I might have to live my fair and equal life. And the final question is true or false? Of the 4 principles of medical ethics proposed by Beecham and Childress, the dominant of these is autonomy. So I was hoping that I got across the point that just because a patient wants something or says that what they want is correct, that in fact there are other principles, and sometimes the patient doesn't always get what they want because it may not be the best thing, not only for society or the institution or the provider. So actually, while we like to believe and our natural instinct is you have the right to do what you want to do as long as it doesn't hurt anybody else, that's not always the case, that you have that right indiscriminately and without taking into account justice, without taking into account the fact that we don't want to hurt anybody, what's best overall. And so I would like to propose, and a lot of neuroethicists are now proposing, or bioethicists in general are saying, you know, whoa, we need to take a step back. Our natural inclination in this society is to say individual first, but in fact we need to take a step back and look at the whole situation, and all principles are not always superseded by that autonomy principle. On that, thank you so much. It was a real pleasure.